All right. So what we're going to do is, in this 5-point vascular assessment, the first step is feeling for pulses. Now, whenever you feel for pulses, I like to make sure you maximize the surface area with your fingers. So never just use one or two, use as many as you can. The first pulse you and I are going to aim for is not on the foot to start with. We're going to go up at the knee. Now, use the butterfly kind of shape, because then it's going to try and allow you to feel something that's not always easy in that popliteal space. But if you were to come with your fingers, thank you very much, Diggle, if you come with your thumbs over the popliteal area or over the kneecap, then wrap your hands around under the popliteal space. Thumbs here, rest of the fingers in the popliteal space, and squish in. And then you're going to find with some of these sets of fingers you're likely to feel a pulse. I'm feeling with these 3 fingers in this position, with my left hand, 3 fingers here, I'm feeling a really strong popliteal pulse. So we are feeling a strong pulse there. The next thing is there are pulses in the feet. And once more I'll try and concentrate by using 3 fingers where I can. The first pulse we're going to go for is the one that goes between the great and second toe, running in something of a line up the foot. What's that pulse called? Can you remember? Yes, dorsalis pedis pulse. Now the pulses in the feet, these arteries don't always run straight and they don't always have a uniform depth, so they can be wavy in their depth and also in their line that they track. So once more, lots of fingers to feel. So I'm going to come along that line and with my 3 fingers, see if I can feel a pulse. Now I can feel a really good one with my index finger. So with that marker that we've used to do our north, south, east and west on our wound, that same marker I'm going to draw an X as to where I felt that dorsalis pedis pulse. Same 3 fingers, we're going to come behind the ankle and in that groove between the ankle and the Achilles tendon. What's this pulse called here?
Posterior tibial.
Yeah, posterior tibial. And with my middle finger I can feel a pulse. So what we can say for Uncle Reg is pedal pulses are palpable, popliteal pulse is palpable. There are going to be many people that you and I will encounter that you may be able to feel a popliteal pulse, but you don't feel their pedal pulse. So that's the first thing, is can you feel pulses behind the knee and on the foot? That's number 1 done. Number 2 is your capillary refill. My preference for doing a capillary refill is you can do it either on the great or second toe, but I like to use 3 fingers again. So I'm going to be using my thumb and middle finger as a clamp and then my index finger to push on the end of that toe. So I'm going to squash, push down and then count. 1,000, 2,000, 3,000. How long does it take before your colour is returned? It means you get to practice Sesame Street every day. 1,000, 2,000, 3,000. What is your normal capillary refill?
That's right.
It can be anywhere from 2 to 4 seconds, and 3 is the one that people often say. So how many seconds for your capillary refill to come back on either this toe or the second? So pulses, capillary refill. Another thing for you to consider is using your thermometer. One of the greatest thermometers and free for everybody. You take it everywhere you go. That thermometer you use on the toes, on the foot, in the gaiter, the calf as you work your way up your leg. If you've got really good perfusion, then you will find that the temperature is uniform up and down that leg. It's not unusual to find you've got somebody that you can't feel their pedal pulses. Capillary refill is now between 4, 5, 6 seconds. And that person, when you do your thermometer, got really cold toes, may have a cold foot, but as you come up the leg, it gets a little bit warmer. So there's your first 3 pulses, capillary refill, your temperature test. 1924, a guy called Leo Berger did something which is now known as Berger's sign. but Leo was engaged with the idea that we should elevate people's legs. So if I take your leg, my friend, and I support the knee, come under the ankle, or on the heel, come up to about 60 degrees. If there was going to be any arterial compromise, we would find that this foot becomes more pale than that foot. What's the term that we use for when a limb becomes pale? It starts with P. Have you ever heard the word pallor? So if that was to become more pale than that, we would say we have pallor on elevation. We can also do our thermometer again. Have our temperatures changed upon elevation. Come on down again, Uncle Reg. If we had this dear Uncle Reg on a bed, an examination table or a plinth, if we were to raise their limb, felt there was a temperature change and there was a colour change, if we had got pallor, I would then be sitting her upright with the leg hanging over the side of the bed and then dropping that leg down. If that foot in a drop down position was to become deeply purple, what do we call that? Starts with R. Have you ever heard the term rubor? Pallor, pale on elevation, red, purple on dependency. Pallor and rubor is Berger's sign. Can I do a favour for me? Over on my little table is my pulse oximeter. Now in 1924, dear Leo did not have a pulse oximeter, thank you, but we do today. I would love you for your graduation present, please, to all buy one of these. This is about $45 worth, and this one has an audible signal. Now, Uncle Reg has given me a bit of a challenge because we've got toenail polish on board. Let's see if we can work with that. So we're going to stick that pulse oximeter over the toe. If it will work, let's see, we should hopefully hear a sound if we can pick up a pulse. And if we can't, I might then try and just rotate that a little. So your toenail polish is dense, so let's try it this way, see if we can pick up something different. Something's happening. You are alive, Uncle Reg. So what we'll do is we'll see if we can now pick up a recording of an oxygen saturation. Aha, we've got 88. Okay, 88, that's 98. 98, that's there. Okay, 98, much better than 88. 98 is there, that's great. Now what I want to quickly do is take that off from the toe, because really my reference point needs to come from the finger. So can I picture your index finger? You're going to pick someone, and lay your hand down flat beside your ear. So this is my reference point, is what happens to the index finger. As soon as you hear a sound, you know you're likely to get a reading. Now we're 98 on the finger, we saw we were 98 on the toe as well. So according to our reference point, we have a similar blood supply as far as oxygenation is concerned at finger and toe. Let's place this over once more onto the toe, see if we get our 98 coming back again. Now once we do allow that to stabilise, what is not uncommon in people who've got really good vascular flow down to their extremity is the oxygen saturation on the index finger can actually be surpassed down here on the toe. People with great blood supply, you may have a 98 but it becomes a 99 or 100 down there. That's not unusual. You are 99, so great result. But let's say for this dear Uncle Reg, I could not feel pedal pulses. I could feel a popliteal, but I couldn't feel these. My capillary refill was 4 to 5 seconds. When I did the temperature test, her toes and foot were cool, the rest of the leg was warm. On elevation and then dependency, I may have seen some pale discoloration and possibly some rubor. But we as detectives, we want to have numbers, we want to measure. So what I can now do with my pulse oximeter on is I will bring this leg up and support it for 1 minute and see what changes with our oxygen saturation. Ideally, you still want that oxygen saturation to be around the reference point. But if that were to drop and start to drop below the reference point, we begin to take notice. You have stayed the same. You're a healthy, remarkable person. So well done. Let's take that off and just bring down, just for one more explanation. Recently I had a patient who I could not feel pedal pulses, I could not feel a popliteal pulse. Capillary refill was 7 seconds. A noticeable temperature difference between the foot and coming up to the calf. Pallor and rubor. She had 96% SATs on her finger. We started around 96% SATs on her toe. But upon elevation, we went from 96%, 94%, we went all the way down to 84%. And did that within that 60-second time frame. Then when we put the leg back down, it took nearly 15 minutes for that to then come back to the reference point of the finger. You and I as detectives collect data. We want numbers. By the time you are talking about the pulses you feel, your capillary refill, temperature variation, pallor and rubor, and then your pulse oximetry, all together these 5 points tell us, do we need to refer this individual for a formal vascularized study? Or is this somebody that there are enough of those markers that were acceptable that we begin compression? But just feeling for pulses alone is not sufficient. We must do all 5 of these things if we're going to be in a position to confidently say we need to refer or that we can begin the treatment.
What is that ratio? We're talking about 5 points of evidence. What? If they've got 3, we would try compressions. Like I know you said Dr. Doolittle will make that decision.
If you're in a position that you've got a worry with any of this data, let's say you've got 3 points out of the 5 where you're concerned, then that is something that I would then be saying to your referral source, your team leader, that you say, here I've got this data, I think we need a formal arterial study before we then carry on with other elements of care. So use your data. Usually if you've got 3 out of the 5 where you've got a worry, then you've got a reason for a referral or calling attention to the situation.
Does anyone else in GP lane, when we're allowed to do compression,
And that's something we're going to talk about tomorrow because we should be changing that. In fact, our patients need us to
allowed to put
change.
tubing on, but not allowed to do proper compression?
So we will look at changing. Yeah, we do need to look at that being a different story. Thank you very much.